Good morning. Although you might be getting this in the evening, but I wanted to at least say good morning to you, each of the members of my psychopharmacology class in in Lebanon. I sure miss you. It's been a long time since we've seen each other. I wanted to give you a quick tour of where I'm going to be giving my lecture for you today on anxiety disorders and obsessive compulsive disorder. This is my office here in California. It's empty right now. No one's here. Not a lot of people are going out. So I wanted to just give you a quick tour to give you an overview of where we are. Uh, this is where I'll be uh, giving the lecture today. It's my main uh, psychotherapy office where I see patients. And this is the waiting room where people wait for me. And this is the hallway that leads to the records room, the bathroom, and a couple of offices on the side. So this is my new practice that I opened not too long ago. So uh, excuse the way I'm wearing. Everybody has been dressing very casually lately because no one is going out, so it's very informal. I hope that's okay with you. Uh, so what I thought I would do is jump right back into where we left off when we started talking about anxiety disorders last time. That was, oh my goodness, over a month ago now. And I know we covered a little bit of the anxiety disorders, but I thought, you know what, it would be probably best if we just started all over again and went from there. And if you have any questions, please go ahead and ask them on the WhatsApp. I'll try to do my best to answer those questions for you to the best of my ability. And this will be a lot better if you have your psychopharmacology PowerPoint, the one that covers anxiety disorders, open and with you while we're doing the lecture today. So what I need to do is I'm recording this on my QuickTime player on my Mac, and I'll put this on YouTube for you. So I'm going to make that window a little bit smaller so I can actually see the slides themselves. So what we'll be doing is going back through slide number 1, and you'll see that introduction section there. So this is, again, in the PowerPoint lecture entitled Anxiety Disorders. You'll see as we go through that point number 1 says that this is the most common class of disorders. And so that is a very good place to start, just with the overall size of anxiety disorders, just given how many people over the course of one's lifetime end up having an anxiety disorder. And by all accounts, anxiety disorders appear to be increasing in terms of their frequency. And it shows no signs of slowing down. And so people that are designing medication to treat mental illness are always thinking about anxiety disorders because there's such a huge market for people who are suffering from anxiety. As we'll come to find out, the antidepressants appear to be working a lot better than some of the classic anxiolytic drugs or the drugs that are putatively designed to treat anxiety disorders. They don't often do as good of a job as the antidepressants. So we also know that anxiety disorders are nothing to laugh at. These are very serious because they, by their very definition, keep people from doing what it is that they normally would prefer to be doing. So there's a huge toll that they have on people. And people that have anxiety disorders also tend to suffer from a lot of other disorders as well. They're at greater risk for substance abuse. They're at greater risk for a variety of other medical issues. And we also know that there are other psychological disorders that they are more likely to have when they have anxiety. For example, you'll often hear therapists talk about the anxiety-depression waltz, kind of like it's a dancing partner because they go so commonly together. There's also a huge cost in terms of lost work, missed time. A lot of people will miss out on school or work because they're very anxious. A very frequent pattern is for people who are very anxious to stay up very late at night and they're not able to get to sleep because their thoughts are racing. By the time they do get to sleep, they have a lot of trouble waking up in the morning because they were up so late from the night before. So when you see people that have that kind of pattern of going to bed very late at night and then having trouble waking up in the morning, anxiety is often a very big culprit. Although it doesn't apply in every single case, a good rule of thumb to remember is that if you have trouble falling asleep, that is often associated with anxiety. And if you have trouble staying asleep, that's often associated with depression or another medical issue. Um, Kind of the classic example of insomnia associated with depression is the person who wakes up maybe 3 or 4 hours before they would normally wake up, unable to go back to sleep, and with a very heavy feeling inside, feeling a lot of despair or despondency. Um, as it is with depression, women are diagnosed more than men in terms of anxiety disorders at a rate of roughly 2 to 1 over the course of a person's lifetime. So that's another issue to keep an eye on as well. There may be some degree of gender bias in that. I think men may do a little bit of a better job hiding their anxiety than women. And so then there may be some cultural expectations that men don't act with a great deal of anxiety about things. And so that rate may be overplaying how many women have it and underestimating how many men actually have it. One of the big myths about anxiety is that it's just not all that serious, that it's no big deal, that it's something that people just need to deal with. They need to stop worrying about it, try to think about something else, and just plow through it. And the reality is that anxiety can be very, very crippling, very, very crippling. In fact, one of the great ways to tell the difference between what we might call normal stress and something that is much more indicative of clinical anxiety is the degree to which someone is paralyzed or not. So stress tends to be motivating, anxiety tends to be crippling and paralyzing. Again, that's a generalization, but it can be a helpful shortcut way of thinking about those issues. Um, we've all heard people say things like, just calm down, stop worrying. And those things are usually very, very unhelpful. In fact, one of the worst things you can say to an anxious person is to calm down. It often makes them more anxious than before, and it has this kind of paradoxical effect. So moving now on to slide number 3 in our presentation, after the title card and then after the introductory slide, are the types of anxiety that are often talked about. These are listed in the DSM, 5th edition. Generalized anxiety disorder, adjustment disorder with anxious mood. Notice that that disorder also has another type that is typically associated with depressed mood. Specific phobias, social anxiety disorder, agoraphobia with panic, hoarding disorder, trichotillomania, body dysmorphic disorder, reactive attachment disorder, which is usually diagnosed in children, anxiety secondary to a general medical condition, a substance-induced anxiety disorder, anxiety secondary to a primary mental disorder. So these are people who have anxious symptoms that go hand in hand with another mental health diagnosis. So a lot of people have a mental health diagnosis and then have anxiety symptoms that are associated with that, or even people who worry about just the existence of a mental health condition. Then there's that old term neurotic anxiety. That's a term that we'll talk about in the next slide. And is a very old term in the history of psychiatry and psychology. We'll get back to that in just a second. And then finally, panic disorder. Notice that in the DSM-4, the previous DSM, agoraphobia was often attached to panic disorder. So when people would be diagnosed with panic disorder, there would be a subtype. You'd have to indicate in the diagnosis panic disorder with agoraphobia or panic disorder without agoraphobia. And now those are treated as two very different standalone disorders. So before, if someone was diagnosed with panic disorder, you would have to specify whether it was with agoraphobia or without agoraphobia. And as you probably remember from your psychopathology class, agoraphobia is the fear of situations in which an escape is unlikely. And so basically agoraphobia generally translates to any fear associated with going outside of the house where you don't have control. The literal name agoraphobia comes from the Greek word agora, or the agora, and this refers to the marketplace, the open-air marketplace where you would see many people, where there would be crowds of people, where you might be subject to a certain amount of scrutiny, where escape might be unlikely. And so you're feeling a little bit of panic in a situation like that. And so, again, those are just two standalone diagnoses at this point. So let's get to that slide number 4 that talks a little bit more specifically about neurotic. The term neurotic is not actually included in the DSM, but it does still show up in our everyday language, in our popular parlance. The term neurotic is a term that usually goes hand in hand with the term psychotic. So psychotic is a term that usually describes people who have a serious mental health condition, people that often confuse fantasy with reality. Whereas neurotic is a term that's usually meant to describe people who are more or less okay. They usually are pretty high functioning. They're usually pretty educated, pretty intelligent, but they still just seem to be plagued by daily bouts of anxiety that makes them unable to relax, unable to be at ease, and they always tend to worry a little bit about something or another. There's always something that's slightly off. So that's a term that you'll still hear people say. You'll hear people every once in a while say, that person's really neurotic. Or you might hear a person say, I'm sorry, I'm being really neurotic right now. What they really mean is just that a person's quite particular. They tend to be kind of picky. They like things to be a certain way. They often have trouble relaxing. They tend to take things pretty seriously. They tend to be high strung. They often are engaging in self-defeating or self-sabotaging behavior. And so Freud, in his original writings on working with anxious clients, or patients as he called them, would use the word neurotic a lot to talk about chronic low-grade anxiety. And usually it's just, again, having to do with people that are pretty high functioning but have adjustment problems. And it's usually the result of a lot of emotional conflicts that are occurring within them. Okay, now moving on to the next slide. We're talking about etiology, and I think you'll remember that we talked a bit about this in class. Etiology, again, is just another name for the cause or the origins of a particular disorder. And so we have to talk about the chicken and the egg question. And the chicken and the egg question has to do with, is it that our body is reacting to things first and then we are responding later with a kind of anxious response and feeling in our emotions that we're very anxious? Or are we very anxious and then that's causing our body to react in a particular way? Sorry about the noise outside, by the way. There's the property manager here is blowing the leaves here early in the morning. It's just a little bit before 8 a.m. And I'm the only one in his office right now. So anyway, here's that fight or flight response. The fight or flight response just refers to a large network of neurological systems and hormonal systems that work together to motivate the body to confront an emergency or avoid an emergency. And a lot of this stuff happens very unconsciously. We often don't know when we go into a fight or flight response. It usually, we find ourselves with a rapid heart rate, with shallow breathing, with perspiration, and we don't consciously wear those things or put those things on. They just naturally happen before we're even cognitively aware of the fact that they've happened. We also know that with other causes that there are brain regions that tend to be implicated in several anxiety disorders. For example, the limbic system, which is a section of the brain that's towards the center of the brain, that's often described as an emotional center of the brain, has several structures that are responsible for an anxious response in people. For example, the amygdala, which is a structure that you should know about or should have heard about at some point in your training. The amygdala is a complicated limbic system structure that's associated with fear. In studies where people have had brain surgery and where they've stimulated different regions of the brain, when the limbic system structure, when the amygdala is stimulated, given electrical stimulation, it produces almost instantaneously a fearful response in people, in the patients involved who are, in some cases, awake during surgery. Another structure that you're responsible for knowing that has to do with anxiety is the locus ceruleus, which is an excitatory structure in the brainstem, and it has been implicated in chronically anxious people as being overly active. So one thing to know in the early emotion studies is that the James Lange theory seems to be the theory that has persisted most strongly in our understanding of when emotions happen in comparison to our physical reaction. So most cognitive psychologists will, based on the Schachter and Singer studies, would say that an emotion is any kind of a physiological response coupled with a cognitive label that we use to describe how our bodies are doing. And the James Lange theory says that our bodies first respond to something that's very anxiety-provoking, and then after that we do our best to come up with some sort of a cognitive label to make sense of what's happening. That, as opposed to the Cannon-Bard theory that argued that the cognitive label or the description comes first or at the very latest simultaneous to the physiological response. But research has borne out the James Lange theory as having won the day. Moving on to the next slide, we're still talking about the etiology, and here we're talking about when the brain becomes anxious, our endogenous braking system begins to kick in, and what this is associated with are chloride ion channels on the cellular surface open up to let in negatively charged ions. So those negatively charged ions that flow into the central structure of the cell do something called depolarizing the cell and make certain cells that are wired in that certain way more or less likely to fire. So that braking system in this case lets in those negatively charged ions, and that is going to cause cells to be less likely to fire, and in this case less likely to fire, and then will calm a person down, hopefully. And that's exactly what benzodiazepine drugs mimic. They bind to these channels, which facilitates the influx of negatively charged ions. So when you have an influx of positively charged ions, it makes a cell more likely to fire, and negatively charged ions makes a cell less likely to fire. The presence of these receptors there legitimates the hypothesis that the body has an endogenous benzochemical present there. It could be adenosine, but we're not completely sure, but it remains an educated guess. We also feel that low levels of serotonin, which inhibit reactivity in the locus coeruleus and the amygdala, could also be a cause of high levels of anxiety in people. One of the ways that this perhaps could explain why SSRIs have been so effective to treat anxiety in some cases, because they increase the amount of inhibitory serotonin in the locus coeruleus. Serotonin tends to have a net negative or net inhibitory effect on a lot of brain systems, including the locus coeruleus. And so one of the things that happens when you take an SSRI drug is that serotonin works to inhibit the locus coeruleus. And the locus coeruleus, the more it fires, the more anxious our response tends to be. Moving on to slide number 7. We're looking at now more specifically at the etiology of specific types of anxiety disorders. And the first would be generalized anxiety disorder. Generalized anxiety disorder is the most commonly diagnosed anxiety disorder. And for people with generalized anxiety, which has also been described as free-floating anxiety, this is a condition where people tend to worry about anything and everything. Which is why they call it generalized anxiety. They might point to specific things that they're concerned about or afraid of, but most of the time people with generalized anxiety worry about pretty much everything. If they feel reassured or if they calm down in one area, there's usually something else that they'll find to worry about. For these people, their limbic systems are in a perpetual hypervigilant state. They tend to suffer from kind of a chronic low-grade anxiety. So even though the anxiety they have tends to be serious enough to warrant diagnosis, it tends to be more, instead of having one bad thing that's overwhelming, they tend to have kind of chronic low-level or low-grade anxiety. So it's pretty much like worry about everything. If this diagnosis were a depressive disorder, this would be more like dysthymic disorder, which is chronic low-grade depression. So with generalized anxiety, it's almost like you have chronic low-grade anxiety. Very interestingly, as common as this is, and despite the fact that many anxiety disorders have a strong degree of heritability attached to them. This is often seen as being primarily psychogenic in nature.